Thank you very much. Welcome all. And I'm here again, and I think we are now about to start our second day section. And as I've said, my name is Sherifat Mohammed Kamal. I'm a senior clinical pharmacist from London. And I will be introducing our first speaker today, who is from United Arab Emirates. And her name is Mrs. Tabrika Muhammad Ali. Mrs. Tabrika Muhammad Ali is an infection control officer at the National Rehabilitation Center, and I'm passing her to the stage to deliver the speech. Thank you very much for coming on board today, and welcome.
Thank you so much for the invitation. It is a great pleasure to be here with you. My voice is clear? It is clear for you?
Yes, yes.
Okay, can I share the presentation or it's...
Yes, you can.
So today our topic will be about the improving patient safety in operation theater from the infection prevention perspective. We'll see so many of the stories. The objective today, identify hazards. I think it's clear for you. You can hear me and see the slides.
Yes, we can. Thank you very much.
So identify hazards that could potentially compromise patient care at operation theater, and what are the implementing proper control to reduce these risks and minimize the impact of hazards in operation theater. So let me start with the story of one of our patients, and this story was taken from Patient Safety Action Network. It's about one patient who had knee replacement, ended up with right leg removal. The story was told by his wife, and what is interesting about this, or what can make us to feel that patient safety is very important. This patient had 14 times to go to operation theater, and finally he ended up with removing his leg. So let us imagine how is the family effect and the social life for him and his family about ending up with permanent disability. And also we can imagine the cost that they had to go for during his treatment and his surgical complication. Grandview Hospital outbreak. This is one of the outbreak that was shared by CDC, which is Center Disease Control, that surgical site infections, and also it is a very important to implement the infection control practices to avoid such complication. And in this study, they shared that they send a message for all the patients who had the surgery in this hospital to go to, when they go to visit the healthcare providers, they have to report that they had a surgery in this hospital, and they have to do the blood test and bacterial test. Here also we can see carbapenem-resistant Pseudomonas aeruginosa infection in Mexico, and this is by WHO, where they investigated that there is a problem or a poor practices regarding reusing equipment and poor processing or sterilization techniques. And also they asked the patient to report any signs of surgical site infection. So from this outbreak and the patient story, we found that patient safety and operation theater environment is very important in regards to patient safety. By in 2014, there is statistics from CDC. They show that 14.2 million operative operations were performed in healthcare setting. And finally, what they found that 800 surgical site infections were associated with surgery. So from this, we can see also the cost and the mortality rate is also high and associated with surgical site infections. So is the operation room is a safe environment for our patient? Let us see. From this study, infection control in operation theater, they found there are a lot of elements that is important to contributing factor to the operation theater safety and design. We can see that storage and sterile processing, traffic control and storage and administrative areas are very important in operation theater designs, contributing to infection control practices. So today we will talk about pre-operative environment, and here I mentioned that will tackle 4 areas: heating, ventilation, and air conditioning setting, traffic in operation theater, and environmental cleaning and surgical attire. So, I think I have an issue with the slides. Sorry for this. I cannot move the slide. Can you check maybe some of the setting or?
It's, I think you should be able to. Once
Okay.
You're fine now. Good.
Yes.
Very good.
Okay, so regarding the surgical attire, what we can see here, normal individuals shed more than 10 million particles from their skin. And we can see here from these 2 pictures that you can see here the full cover and the improper covering of the hair. And this is also will contribute to the microorganism present in the air in the operation theater. So what is Aaron's recommendation regarding this? We have to wear a clean, low-length surgical head cover with the hood, confine all the hair and confine scalp skin. And it also minimizes the microbial dispersers in the air. Head covers, what is the recommendation or what is happening now when we are going as an infection control to the operation theater? We can find that there is non-compliance with the head covering. And we have an issue with that because dandruff increase bacterial presence and shedding. And what we have to do is completely cover, and also we instruct the staff to have a treatment for the dandruff. Also, some of the skin condition also can pose a surgical site infection rate. So what we are instructing our line managers also to inform their staff to report and to keep an eye on this and to have a treatment and use the full cover. Place head covers to be done first, because when we are instructing the staff how to wear the personal protective equipment or the surgical attire, they have first to wear the head cap to avoid contamination of the other attire or PPE. Why it is important? Because we know from many studies that the hair is a source of staphylococcus, which is a normal colonizer for our skin and hair. You can see from this picture what is the proper surgical attire that should be worn in operation theater. And what we for infection prevention, as when we go to operation theater, actually it is one of the critical area that we need to keep eye on this, because operation theater is not accessible all the time for us. We are not doing a daily round for that. So we have to give a proper training and instruct the staff what are the proper surgical attire to be worn. As you can see here, it is a long sleeve, combined, and also the head cover is covering all the head, face mask, and the goggles, and each one has an indication. Also, the accessory that cannot be contained within the scrub or the surgical attire should not be worn. Shoes are clean and dedicated only for pre-operative environment. Personal items don't belong in operation theater. We know that many of the items that we are using, we're moving it from the office to the table to the tea room area. So these items are not belonging to operation theater, as it is very difficult to be cleaned. And also the pathogen can survive for a long time, and it likes to survive in a plastic and fibrous. And also it will be transmitted from place to another place. Accessories and personal, also clothing, it's not recommended to be worn in operation theater. What we have to do, if you are wearing the personal clothing, it should be combined and completely covered by the surgical attire. Also, the wearing of accessories increase bacterial counts, and there are many of the studies proved that rings and bracelets have a lot of the microorganisms that it is colonized with. Removing watches and bracelets allow for more thorough hand washing. Scrubs and jacket in operation room. A facility approved to clean freshly laundered surgical attire should be done in a designated area. This is related to the design in operation theater. So the infection control recommendation always to have a specific dressing room at the entry of or re-entry of the facility. If the scrubs are worn outside the institution, should be changed when the staff are coming back to the operation theater. And we don't recommend, or the guidelines don't recommend, home laundering for the surgical attire because there is no monitoring, and we have the inspection or the quality audit for that area to make sure that the processing is done properly. Non-scrubbed personnel should wear long sleeved jackets and are buttoned or snaps closed during the use. And also what is important during an emergency, what is we recommend to the staff in case of emergency and the surgeon wants to go out of the operation theater, they have to wear a coat and attend the case, and when they come back, they have to change to a new surgical attire. Moving to the heating, ventilation, and air conditioning system. What is the purpose of the heating ventilation system or design? It is to maintain air quality, temperature, and humidity. And we know all that temperature and humidity in operation theater all over the hospital area is very important. This is for patient comfort, and from infection control and prevention, it is the increase in humidity. It also encourage or promote the growth of fungal infections or fungi in general. Control odors and remove contaminated air from the hospital environment, facilitate air handling requirements to protect susceptible staff and patient and visitors, and minimize the risk of transmission of airborne diseases or pathogens from infected patients. And as we know, during the pandemic, the air conditioning or ventilation system is very important, and it had played an important role when we instruct our facility engineers to check how many air exchange we have, how is our HVAC system working, because during the pandemic, we had to have proper ventilation in our facilities. Air quality, and there are many issues that affect the air quality in our facilities, such as decreased performance of healthcare facility HVAC system, poor maintenance, filter insufficiency and inefficiency, and improper installation, accumulation of dust and moisture within the HVAC system. And these factors actually when only will be identified either when we have an outbreak or we are doing a site visit, a regular inspection, and also we have an overlook during the facility maintenance when they are submitting the reports to the infection control to check for the air quality testing. Air quality, the recommended air exchange required for operation theater is 2 air exchange per hour or more than that, and at least 4 of them from out there, or they can call it in some of the literature, they call it 20% fresh air should be for operation theater. Air sampling, is it recommended or no? Many of the literature, actually this is one of the area that it's still till now, it is under study. Outbreak, if we have a surgical site infection, from our operation theater, and we want to investigate what are the reasons. If we check all the elements or the practices, and then we have to go to the air sampling to to identify if there is a possible transmission from the air. Possible renovation and construction, or post-renovation and construction. When we are doing a construction and renovation in our operation theater, to make sure that the filter and the design is working properly, we have to do an either air particle or air sampling. And also we have the risk assessment. So actually in operation theater, there are multidisciplinary team. We have the facility team, and we have the safety team, and we have the operation theater, and the surgeons, and the team leaders, and the infection control also. So we have to sit together in one table and discuss what are the frequency we need to do in our operation theater to check the air quality. There is no certain recommendation, but it is based on our risk assessment. You want to do it quarterly, you want to do it every 6 months or yearly to check that air quality is within the normal limits. This is just to share that there are still many of the unresolved issues associated with microbiological air sampling. As you can see, there are different methods of the collection of air sampling, and there is also different interpretations. So we have to follow the manufacturer recommendation if we are using new technologies for air sampling. So moving to the air quality strategies. Here we have to, as I mentioned already before, that engineering and manufacturer recommendations should be followed for preventive engineering and optimal performance of the filters. Especially some of the manufacturer will tell you you need to change it every 6 months. Some of them, they will tell you within 1 year. So we have to follow that. We have to put a policy, how frequently we need to change it, how should be the facility department or FMS, facility management team, they have to do the maintenance, monitor area with the special ventilation requirement, using a manometer. For example, if we have an area with like operation theater, we have a positive pressure rooms, how frequently we have to check it, like we need to do it daily or every shift according to our risk assessment and facility policy. We have to inspect the HEPA filter periodically to check the maintenance, as we discussed before. Remove the birds, roots, and nests near the air intake. And usually when the infection control team with the facility, they do walk around visit or site visit to go and check the building and what are the infection, or they do the annual risk assessment. So when they go these rounds, they identify what are the possible risks that can affect the operation theater and quality of the air. Prevent dust accumulation by cleaning air ducts, grills, and now many technologies and robots, they are available in the market that help to make the work easy for duct cleaning. Airflow and air pressure, what is the difference? In ORs, the design to the airflow should in the top of the room and is exhausted at the bottom of the room. Unidirectional to reduce the contamination of the surgical field. So positive pressure, how we can monitor that? We usually teach the there are different, either to make it practical, we use the tissue test, or we use the smoke test. What is available in the facility, because not all the facility have the same resources. So the easiest one is using the tissue test when it is coming outward. That means there is a positive pressure and it is working properly. The frequency, how to test it. As I mentioned before, that risk assessment can be done if you want to do it every shift, or it is once daily according to the facility policy. Temperature and humidity. Cold temperature standards should be maintained 18 to 23 centigrade in sensitive places such as operation theater, which is one of the important factor to prevent surgical site infection. Warmer also temperature in other areas to improve the patient comfort is very important. And many of the devices we use it to warm the patient, especially after surgery, as they will have shivering. Humidity, mixture of water, vapor, and air. And what is the normal limit? From 30% to 60%. We don't recommend more than 60%, or it is not recommended because of the uncomfortable, and also, as we mentioned, promote the fungal growth. So if we have a humidity issue in our operation theater, what we should do? Air sampling is one of the parameters for functional and safe operation rooms, but it is not the only one. So we have to look for other possible actions that to identify what are the reasons for the humidity issues in our facility. Sterile items should be removed immediately because we mentioned that increased humidity, increase microbial growth. Standardized method of humidity monitoring to give valid data and also to compare from our baseline. I share this dehumidifier. Actually, we had an issue with our operation theater. We had issue with the humidity, and our facility department, they advise us to use the dehumidifier. And the infection control committee, we strongly didn't recommend this because this is only temporary solution, will not solve the problem. Will not solve the problem permanently, and also there is an issue with that. Pressure variance and disturb airflow patterns, and like air conditioners draw air much closer to the ground. Also, it will increase the circulating of contaminated air associated with the surgical site infections. Excuse me, I need to move to just make the light, or it is okay, am I okay with that? Is that okay, or continue like that?
Yes, that's fine.
Okay, see here in the picture, we can see different type of hygrometer used to monitor the humidity in operation theater. And also here you can see different type of dehumidifier. As we mentioned, dehumidifier is not recommended because it will change the pressure variance. It will make, there is no filtration of the air. And also it will recirculate its contaminated air in the environment. So when we have an issue with the humidity, we have to do root cause analysis and try to find permanent solution that will, the advantage is more than the disadvantage. Laminar flow and exhaust suits, if there is no data to support that there is a surgical site infection reduction, and here is the references that there is no studies proof that it will reduce the surgical site. Although many of the literature, when they are talking about orthopedic surgery, they mention that laminar flow air is recommended to reduce the, to make unidirectional and improve the air quality. Foot traffic and door openings. Here is a study done by one of the literature for the cardiac surgery. They mentioned that investigators noted 10 among patients who developed SSI toward increased frequency of door openings. And it is one of the actually the best practices to control the door openings in operation theater, and also to reduce the personnel to a minimum number. Only the needed personnel should be inside the operation theater to minimize the microbial load in the air. So what we have to do if we have an issue with that, we have to coordinate supplies, because we don't want our staff every time to go and pick some items from outside. We have to prepare the area and prepare the items, all what is needed to be close to our access. No need to every time to open and go and reduce the door openings and arrange the supplies. Actions when the heat and ventilation system actions are affected, what we have to do, reschedule or redirect procedure to the areas of surgery suite, close the OT, and this is a very challenging decision because it is not the only infection preventionist or infection control team decision, it is multidisciplinary team. Delay elective surgeries and limit the surgical to only procedure that is life-saving procedures. Moving to the environmental cleaning, what we have to know or what we have to do, how to evaluate the cleaning procedure. Is it sufficient enough to improve the patient safety, improve the cleaning practice in our facility. Terminal cleaning procedure, how is it in our evening and night? Is it the same like in the morning shift? All these questions we have to think about it and evaluate it from infection control point. Are there sufficient staff to terminally clean? Always we hear complaining that, especially now with the pandemic, we have a lot of staff that sometimes we have an exposure and the staff are not enough. So what we are doing to manage this situation? So cleaning practices are often suboptimal. You can see here in the picture that over bed table before cleaning, you can see here the number, and over bed table after the cleaning, it is spread more. So what was the issue? How it came like that? Either we have a poor trained housekeeping, they don't know how to do the proper cleaning. Do we have the proper disinfectant, EPA approved they are using? Are they following the manufacturer recommendation in dilution and contact time? So the cleaning practices is not only just to clean it, is how to clean it and when to clean it. Daily cleaning of services near patient is often performed poorly. Unfortunately, when the infection preventionists, we go to the round, we found that the highly touched services always there is a challenge and we found it dirty. Here, one of the study Carling found that only 47% of services targeted for terminal clean had been clean. So imagine that more than 60% or 50% is still not cleaned properly. So who should clean what? This is also one of the challenges. Sometimes when we go around, we ask our housekeeping, did you clean this? It is not my responsibility. Then who is responsible for it? So infection preventionist has the important role to identify the responsibility of each professional category in terms of cleaning and disinfection. So our policy should be always continuous process, or the cleaning should be continuous process. Cleaning procedure involve the principle of infection prevention, which is the following the best practices, cleaning from clean to dirty, following the manufacturer recommendations, cleaning standards, and frequently and accountably, we should define who cleans what and when and how. Cleaning schedule to cover all the areas and it should be documented. The key factor for cleaning is use of friction. It is not the only gentle cleaning. We have to do the proper friction to remove the microorganism and debris. And also we need to use the EPA approved disinfectant and follow the manufacturer recommendation. Hot topic due to recent outbreak. This is one of the important elements, also the sterilization of instrument and cleaning and disinfection. It needs a lot of explanation, but I put this slide just for us to remember that inspection of instrument is also an important factor, and especially this dedicated equipment. Sometimes it's very difficult to clean it, disassemble it, and there is a huge kit that it is very difficult to clean it at the point of care. So it is very important also for the operation theater staff who is dealing with this instrument to clean it at the point of care, disassemble it to avoid an outbreaks. Pre-soaking and rinsing of tissue, blood, and blood from the instrument before sending it to decontamination. This is what I said already, is about cleaning it at the point of care. The handling of COVID-19 in operation theater. This is one of the nice studies. It is systematic review, and they reviewed 30 articles regarding handling of COVID-19 patient in operation theater. For infection preventionists, it is the same principle what we do in dealing with airborne diseases. We have a strict protocol how we do if we have a patient with airborne. But the difference here is how to transport the patient, because the transmission of COVID-19, we know that it is faster than any other, like the TB. Handling COVID, and the first thing is all elective surgery and endoscopic cases should be postponed. We know that elective surgery during the pandemic, we stopped all the elective surgery, and still till now, if we have in our country that there is a surge number of COVID, again, we reevaluate and do the risk assessment, and then we have to stop elective surgeries. Using of N95 mask or FFP2 masks, it is recommended, especially if we have that confirmed cases with coronavirus that needs an emergent or urgent surgery. And they are preferring to use BPR or purified air, powdered air purified respirator for longer operation, because N95 mask, it will not make the staff comfortable. Handling ventilator when they are especially intubation and extubation is very important to reduce the aerosolization risk. The transfer from ward to OT should be done by the ward nurses when they are wearing full complete PPE. Minimize personnel, as we mentioned already in operation theater. In general, we have to keep only the needed staff. Recovery in operation room. So if the patient finished the surgery, we don't need to contaminate other area in operation theater. We recommend it is recommended to keep him or her in the operation room itself till he fully awake. If available, use portable HEPA filter. And this is the HEPA filter. Already we know that it became one of the important resources needed during a pandemic. Disinfecting personnel who should enter the operation theater should be only when we have the complete air circulation to remove infectious particles. This is also one of the screenshot I took it from the study that recommend operative complex to be divided in 5 zones. According to the facilities design, it is very difficult how to redefine the area, but it is also one of the challenges that all the hospitals and all over the world, they review the design of the hospital and keep an entry designated only for wearing the PPE and an exit room for removing the PPE and how to handle the COVID patients or dealing with the pandemic in general to reduce exposure and reduce the contamination. What is infection preventionist role in pre-operative setting? Building a partnership with the pre-operative team, because infection preventionists, we need to be cooperative with our surgeon, with our operation theater team in order to make the patient safety a goal for all of us. Engaging surgeons and pre-operative leader and the use of surgical site infection data to get their support and advocate to improve the patient safety using validated or facts. Acting as a change agent and speak up when we see non-compliance with infection control practices. Application of regulatory and accreditation requirements to pre-operative care. Of course, here we have the JCI, we have the Ministry of Health, we have the Department of Health, we have many requirements from our authority. We have to fulfill the requirements. We have to serve as a source for a problem investigation, risk mitigation, and also we follow the recommendations from international or evidence-based practices. Perform regular audit and share the result with the team using an approved checklist, and education and training is one of the key areas for infection preventionists to develop the team. This is just a sample how we are doing the audit. Here you can see the environment, equipment, and staff training. Many elements should be included, and finally you will come with an overall compliance rate. What is the percentage? Share it with the team, make a multidisciplinary team, and work with the action plan together with the team. And this is my references. Thank you for listening and stay safe.
Thank you very much. Thank you very much, Mrs. Tabrika Ali, for that a very, very educative and informative section. You're telling us mostly about improving patient safety in operation theater environment. And you've gone through so many stages within what we need to do with the equipment and with the personnel as And just for us not to take much of your time, I don't want to repeat what you've already said. I'll just give 2 minutes for if anybody has got any questions or anything to add on, and 2 minutes before we go on to the next speakers. We still have space where we can have a general speaker at the end of the conference, but we can give 1 or 2 minutes to anybody that needs to say something before we go to the next speaker. You can put it on the chart and we can read that out. Alternatively, if you can raise your hand and we can really listen to you. Thank you very much.
Thank you.
We're still waiting. And once again, we welcome everyone to this edition of our 8th conference. And we hope you are enjoying the speakers. So you can still write your questions and we can take them at the end of all the talks at any time. And so thank you, Mrs. Maria Melo, for congratulating us for the event organizers for this interesting episode. And thank you very much. And thank you very much, Mrs. Tabrika, for that informative talk. It's really, really informative. And I know I've spent some time within the hospital, but now I can see what is happening within the theaters.
Thank you so much. And I am glad to be with you. Thank you so much for all the speaker. I will be here with you, inshallah, today.
Inshallah. Okay.
Thank you.
And Ms. Lina Oboid, thank you very much for sending your thanks. We quite appreciate that as well. And I know it's 9:30, and I would like to introduce our